I will be explaining about the profile of our selected ministry. The Ministry of Health Malaysia, also known as Kementerian Kesihatan Malaysia or KKM, is the government body responsible for public health and healthcare services in Malaysia. It was established in 1963 and is headquartered in Putrajaya. The ministry manages healthcare services across the country, including disease prevention, treatment and rehabilitation. Its vision is a nation working together for better health, which highlights the importance of cooperation between the government, healthcare professionals, and also the public. Its mission is to lead and work with stakeholders to help Malaysians achieve their full health potential. The Minister of Health is currently led by the Minister of Health, Datuk Sri Dr. Zulkifli Ahmad, with support from senior officers. Overall, the ministry plays a key role in improving public health, ensuring fair access to healthcare and also responding to health challenges in Malaysia. So, our project title is Klinik Bergerak Rahmah, Inisiatif Kesihatan Bergerak untuk Komuniti Terpencil. We choose this title because we want to address real healthcare gaps, especially in rural and scattered areas. The responsible agency for this project is the Public Health Division of Malaysia. It is a department under Ministry of Health of Malaysia. Public Health Division oversees healthcare services in all areas of Malaysia, especially in rural and also scattered areas. The success of the Klinik Bergerak Rahmah program depends on strong collaboration between government agencies, community leaders, and also non-governmental organizations. At the community level, village chiefs play an important role by spreading information, organizing residents, and also ensuring smooth clinic operations. At the government level, the Ministry of Rural and Regional Development supports the program by providing logistics and also access to rural and remote communities. In addition, collaboration with NGOs such as Mercy Malaysia enhance service delivery through volunteer healthcare professionals and also mobile health expertise. Together, these partners help to ensure that mobile healthcare services effectively reach underserved and vulnerable populations. Furthermore, I will be explaining about the background of this project. Malaysia continues to experience significant urban-rural healthcare inequality, where access to healthcare services is much better in cities compared to rural areas. Many rural communities, especially in Sabah, Sarawak, and also interior regions, face geographical and access barriers, including long travel distances, poor road conditions, and also challenging terrain. These barriers result in negative health impacts such as delayed treatment, undiagnosed chronic diseases, and also higher overall disease burden. The Ministry of Health has acknowledged that fixed healthcare facilities alone are insufficient, as building permanent clinics in every remote or scattered settlement is costly and not sustainable. Therefore, these challenges form the background and justification for introducing mobile service clinics to improve rural healthcare areas.
Many rural communities in Malaysia still struggle to access healthcare because clinic and hospital are far away and often lack sufficient staff and facilities. Furthermore, non-communicable diseases such as diabetes and high blood pressure are increasing, yet villagers find it difficult to go for regular checkup or follow-up treatment. In addition, long travel distance and high transportation costs make it even harder for rural residents to seek medical care, especially for those with limited income. So with this, many illnesses are detected late or left untreated, which leads to poor health outcome and greater health risk for the community. Therefore, these challenges clearly show the need to bring healthcare services directly to rural areas so that communities can receive timely and proper treatment.
This program mainly targets P40 communities who live in deep rural and outskirt areas across Malaysia. This group often face serious challenges in accessing healthcare because they have limited transportation option and need to spend more money to travel long distance for medical treatment. Compared to people who live in urban areas, rural population have lower access to primary healthcare facilities, which reduce their tendency to seek early treatment. Therefore, this program is designed to ensure that these vulnerable groups are not left behind and can receive basic healthcare service more easily. For the expected outcomes, our program focuses on outcome 3, which is to ensure primary healthcare services are accessible, equitable, and of good quality, especially for communities living in deep rural and outskirts areas. Through this program, basic healthcare services such as health screening and simple consultation are brought directly to underserved communities. This reduces geographical barriers, ensures fair access to care, and allows early identification of health risks among rural residents. Among the listed indicators under Outcome 3, the most suitable indicator for our program is the percentage of home-based care or perkhidmatan perawatan domiciliary patients who show improvement in activities of daily living within 3 months. This indicator fit our program because we focus on community-based care, early screening and referral of elderly and high-risk patients rather than digital service or clinic-based system. Based on our indicator breakdown table, the program will cover 43 outskirt areas nationwide. On average, about 5,160 residents are expected to be screened, with approximately 20% identified as elderly or high-risk patients suitable for PPD referral. In line with the national target, we aim for 70% of these patients to show improvement in their daily functioning. This demonstrates how our program directly contributes to strengthening accessible, equitable, and quality primary healthcare service in rural Malaysia.
The main goal of Klinik Bergerak Rahmah is to improve healthcare access for rural communities by bringing basic medical services directly to villages that are far from clinic and hospital. First, the project is to ensure villagers can receive fast treatment for common illness such as fever, flu, minor injection, and also small ones. This helps to prevent health problems from becoming more serious. Second, the mobile clinic also identifies serious cases early and safely refers them to the nearest hospital. Patients who need further tests or emergency care will be transported immediately using the clinic's van. Third, the project helps to reduce long travel and high transportation costs for rural families by providing treatment closer to home. And lastly, Klinik Bergerak Rahmah improve overall community well-being by ensuring continuous access to essential health services and strengthening the connection between rural residents and the formal healthcare system.
The next one is methodology. The project adopts a phased implementation of methodology to ensure a systemic planning, efficient resource utilization, and effective delivery of healthcare services to rural areas. This project is divided into 5 main phases, which is the first phase is planning and coordination, which happening in January 2025. It is to confirm the project scope, to identify those rural and outskirts areas, to coordinate with head villages and authorities, and to set up a team to conduct the project. The next phase is procurement and preparation, which is happening in February 2025. This is to purchase 43 vans and modified vans for basic healthcare and to feed basic tools. Lastly, to recruit volunteers and train medical assistants and drivers. The next one is phase 3, which is the implementation cycle 1, which is happening between March and May 2025. The cycle 1 includes to deploy vans to deep rural areas, conduct basic health checkups and consultations, and collect patient health data and service usage. Patient data will be updated through My Sejahtera for those who have a mobile phone, and to those who doesn't will be updated manually by the staff. Next is phase 4, which is the implementation cycle 2, happening between July and September 2025. This is a second round of deployment to the same or new rural areas and a follow-up health checkups and referrals. The last one is monitoring, evaluation, and reporting, happening between October and December 2025. This to monitor overall performance, evaluate outcomes from both cycles, and prepare final report for the Ministry of Health and Ministry of Finance. For the venue, we focus to serve B40 communities who live in rural and remote areas in Malaysia. This program also will cover villages which is located in 13 different states in Malaysia, including East Malaysia. 3 villages in each of states in West Malaysia was picked as our destination, and 5 villages for East Malaysia, which is Sabah and Sarawak.
This program is implemented over 1 year, but the outreach activities are carried out once every 6 months, which means the program runs twice a year. This approach is more practical for deep rural and outskirt areas because it allows better planning, manpower management, and follow-up care. The first phase is planning and coordination, which take place in January. This phase, the project scope is finalized, 43 outskirt and deep rural areas are identified, and coordination is done with the village heads and local authorities to ensure smooth outreach activities. The second phase is procurement, preparation, and training, conducted in February. In this phase, all vans are prepared and equipped with basic healthcare tools. Medical assistants and drivers are also trained on basic health screening procedures, patient handling, and safety measures, especially for operation in remote areas. The third phase is implementation cycle 1, which runs from March to May. During this cycle, the mobile clinic are deployed to selected deep rural and outskirt areas to provide basic healthcare service such as health screening and basic consultation. The fourth phase is implementation cycle 2, which take place from July to September. This second cycle focus on follow-up visits, continued screening, and referral of high-risk and elderly patients to appropriate healthcare facilities, including home-based care service. Finally, the last phase is monitoring, evaluation, and reporting, which runs from October to December. During this phase, the overall performance of the program is reviewed, outcomes from both cycles are evaluated, and a final report is prepared for the Ministry of Health and the Ministry of Finance.
Next is the budget allocated for personal allowance and insurance under the Klinik Bergerak Rahmah program. It includes allowance for trainers, drivers, nurses, and health officers involved in these mobile clinic operations. Special initiative allowance are also provided for professional health officers to support service delivery in rural areas. In addition, the budget covers life insurance and vehicle insurance to ensure staff safety and also operational protection. The total estimated cost for this component is RM600,000 and 710. Next is the budget allocated for personal allowance and insurance under the Klinik Bergerak Rahmah program. It includes allowance for trainers, drivers, nurses, and health officers involved in these mobile clinic operations. Special initiative allowance are also provided for professional health officers to support service delivery in rural areas. In addition, the budget covers life insurance and vehicle insurance to ensure staff safety and also operational protection. The total estimated cost for this component is RM600,000 and 710. Next is the budget allocated for personal allowance and insurance under the Klinik Bergerak Rahmah program. It includes allowance for trainers, drivers, nurses, and health officers involved in these mobile clinic operations. Special initiative allowance are also provided for professional health officers to support service delivery in rural areas. In addition, the budget covers life insurance and vehicle insurance to ensure staff safety and also operational protection. The total estimated cost for this component is RM600,000 and 710. Next is the budget allocated for personal allowance and insurance under the Klinik Bergerak Rahmah program. This slide outlines the operational and logistics budget for Klinik Bergerak Rahmah. A total of RM15,301,769 is allocated for medical equipment, transportation, vehicle rental, utilities, food and beverages, and also pilot testing. This includes RM15,050,000 for the purchase of vans and RM99,330 for vehicle servicing. These costs ensure mobile clinics can function effectively in rural and outskirt areas. The overall project budget amounts to RM15,902,479. This slide outlines the operational and logistics budget for Klinik Bergerak Rahmah. A total of Rm15,301,769 is allocated for medical equipment, transportation, vehicle rental, utilities, food and beverages, and also pilot testing. This includes Rm15,050,000 for the purchase of vans and Rm99,330 for vehicle servicing. These costs ensure mobile clinics can function effectively in rural and outskirt areas. The overall project budget amounts to Rm15,902,479. This slide outlines the operational and logistics budget for Klinik Bergerak Rahmah. A total of Rm15,301,769 is allocated for medical equipment, transportation, vehicle rental, utilities, food and beverages, and also pilot testing. This includes Rm15,050,000 for the purchase of vans and Rm99,330 for vehicle servicing. These costs ensure mobile clinics can function effectively in rural and outskirt areas. The overall project budget amounts to Rm15,900,000.
As for the monitoring and evaluation framework, the first one is continuous monitoring of implementation and service delivery. So ongoing monitoring tracks mobile clinic activities, coverage of rural and hard-to-reach areas, service utilization, referrals, and community participation using standard data collection tools and regular reporting. Next, performance measurement against objectives. So key performance indicators assess success to healthcare quality and consistency of services, effectiveness of referrals, equity for rural communities, and patient satisfaction through healthcare worker reports and community feedback. The last one is impact evaluation and continuous improvement. So long-term impacts on rural health outcomes, early disease detection, healthcare access, and reduction of the urban-rural gap are evaluated to actually inform improvements, policy decisions, and future mobile clinic initiatives. Next one is the three main points of sustainability and impact. The first one is we are able to ensure sustainable healthcare access and capacity building. So this program promotes long-term sustainability through digital health literacy, preventive health education, alignment with national health strategies, cost-effective early interventions, and capacity building of healthcare staff and volunteers in rural areas. The second one is reduction of healthcare inequality and improve health outcomes. So Klinik Bergerak Rahmah 2025 addresses urban-rural healthcare disparities by improving access to timely care, enhancing management of non-communicable diseases, reducing preventable illnesses, and strengthening trust in digital and mobile healthcare services. The last one is broader social, economic, and national impact. So this initiative supports national health equity goals, contributes to economic productivity through healthier communities, and encourage adoption of telemedicine and aligns with global health and sustainable development objectives. To conclude, Klinik Bergerak Rahmah helps reduce healthcare inequality by bringing medical services directly to rural communities. So with support from local leaders and healthcare workers, it promotes healthcare for all and improves quality of life in rural Malaysia.
Last but not least, there are 3 recommendations for this program. The first one is institutionalize mobile clinic as a permanent primary care arm. Mobile clinics program should be formally institutionalized as a permanent component of Malaysia's primary healthcare systems rather than being a temporary outreach program. By getting mobile clinic officially recognized, the government can ensure the continuity of the care for rural and remote areas across Malaysia. The second one is promote interministerial and state-level coordination. An effective mobile clinic delivery in rural areas requires a strong coordination between interministerial and the state level. The collaboration between MOH and Ministry of Rural and Regional Development, state government, local authorities, and a social welfare agency should be formalized where an agency plays a complementary role. And the last one is incorporate climate and disaster responsive mobile clinics. Due to high exposure to floods, landslides, and disease outbreak, mobile clinic can be strategically designed and equipped to function as a rapid response healthcare unit during emergency, especially in areas where fixed facilities are limited.